Hello, my name is Demetrios Maroutsos. I'm an M4 student at the University of Illinois College of Medicine, Peoria, and today I'm presenting Stauffer's offer, a description of a rare paraneoplastic syndrome seen in renal cell carcinoma. Now, our patient is a 65-year-old African-American male smoker with a past medical history of cocaine and heroin abuse, a remote history of alcohol abuse, and hypertension, who presented to the hospital with insidious onset persistent abdominal pain, weight loss, and fatigue. He did not regularly see a physician. The initial physical exam was remarkable with cachexia, ascites, and right upper quadrant abdominal pain without guarding. In the emergency room, our patient received 2 units of blood with subsequent improvement in hemoglobin. He also underwent non-contrast CT scan, whose results can be seen in Figure 1. Upon admission, urology and oncology were consulted. Our patient underwent paracentesis with 600 mL of fluid removal. He also underwent MRI and retroperitoneal lymph node biopsy. MRI results can be seen in Figure 2. As far as the lymph node biopsy, immunohistochemical staining showed PAX8 positivity, suggestive of metastasis from a renal primary. Patient also worked on pain control. As far as discharge, our patient was discharged to home with his sister, and he was scheduled for outpatient oncologic therapy, where he then decided to pursue palliative care. Now, as far as diagnosis, there are no formal criteria for Stauffer syndrome, but the classical syndrome has the following symptoms, and bolded are the symptoms which our patient has also exhibited. Some of these tests were not tested, and also the resolution after primary tumor resection was not able to be evaluated because our patient was not a good surgical candidate. His workup showed hypoalbuminemia, elevated gamma-glutaminotransferase, high alkaline phosphatase, prolonged growth thrombin time, elevated ESR with thrombocytosis, normal transaminases and bilirubin in the absence of liver metastases. All of these are consistent with the classical variant of Stauffer syndrome. The laboratory test values are shown below. Currently, there are 3 proposed mechanisms for Stauffer syndrome. The first, most popular hypothesis includes primary tumor secretion of IL-6 leading to cholestasis. One study showed reversal of Stauffer syndrome laboratory manifestations with anti-IL-6 antibody treatment. The second proposed mechanism is due to culinary stimulating factor-mediated hepatosplenic damage, in which athymic mice were inoculated with Stauffer syndrome renal cells, showing that syndromic appearance in the mice, and improved with naphthylurea suramin, which is a known CSF inhibitor, showing improvement in the symptoms. And third is an autoimmune pathophysiologic process that has also been proposed. As far as discussion, our case highlights the presentation of a poorly understood and uncommon paraneoplastic syndrome. Our workup was consistent with classical Stauffer syndrome, and also of note, after an extensive literature search, we did not find any cases of Stauffers also having ascites. However, malignant ascites is an extremely rare presentation of renal cell carcinoma. Stauffer syndrome overall is associated with 3 to 6% of patients with renal cell and usually portends to a poor prognosis for our patient. Now I'd like to conclude with 5 points that highlight our case for our academic interest. First, Stauffer syndrome is a rare disease whose understanding can help further our understanding of renal cell carcinoma and other paraneoplastic syndromes, as well as hepatobiliary physiology. Second, we'd like to highlight that a formal diagnosis protocol has not been established, and the latest in literature does not account for post-surgical resection. Third, we'd like to raise awareness that cholestasis without a clear etiology may be a sign of underlying malignancy. Fourth, we'd like to present another rare instance of ascites secondary to renal cell carcinoma. And fifth, we'd like to stress the importance of shared patient decision-making, adequate pain control in cancer with history of drug abuse, and the role of palliative care in ensuring patient and physician treatment goals. Overall, I'd like to thank you for listening to my presentation. Once again, this is Demetrios Maroutsos, M4 student at the University of Illinois College of Medicine, Peoria, presenting Stauffer's offer, description of a rare paraneoplastic syndrome seen in renal cell carcinoma. Thank you.